Good morning, everyone. Welcome to Open Data Saves Lives, the ODI Leeds. We've got lots of people joining us from all over the country. So people are still entering the waiting room, and we're letting them in. So this morning, Stephen Mortimer Locke, you're there, Steve, so that's good. So you're talking about your dashboards.
I made it.
So today we've got a really interesting session. What we're talking about is data and dashboards, and lots of people are interested in communicating data and dashboards and what's happening. So what we're going to do today, we're going to have Stephen from the NIHR is going to talk about the work they were doing in presenting data in their dashboard, which is great. Then Stuart from ODI Leeds is just going to talk us through. We did a bit of an experiment in using the PHE data to do a West Yorkshire dashboard. One of the best things we've done, because we've got a load of feedback about what was good and what was bad about it. It's quite interesting where we're down with that. So we're going to just talk through that. I've just checked on our dashboard. It's not working at the moment because the PHE API is down, but we'll check to see if it's back up again. But that's part of the chat as well, is to just let's go through that data. And then we've got a quick Google document, which we'd like your input on. And we want to do a very rapid piece of user research about what we think would be useful in our dashboard. You might have seen me on Twitter having some conversations with people about whether the John Snow map was any good or not, or whether we should use that. And maybe taking a bit of an extreme point of view in publishing everything, but it's good to have that feedback. So we'd love to have you to join in and help us shape that, and then obviously we'll share all the findings from that. So Stephen, if you would like to introduce yourself, tell us what the NIHR have been up to, and we'll kick off. I think most people are in the room, so yeah, thank you.
Okay, good morning, everybody. I've actually got a couple of slides to show you, and I'm going to tell you a little bit of a story. So if I can just remind myself how to present. Sorry for being useless. We don't use Zoom all the time. We're Google people. I can't see an option anywhere where I can present. Is that just, am I just being slow?
Steve, on the bottom, there should be a share screen thing in green.
Oh, gosh, in bright green, yeah. Right in front of me. Sorry, everybody.
Yeah. You just click on that.
With you in a second.
Yeah.
Okay. There we go. Hopefully you've got that started now.
Yeah.
Good. Just 1 second. So, morning, and thanks for the invitation. So my name's Stephen Locke. I'm the interim Chief Information and Technology Officer at something called the National Institute for Health Clinical Research Network. And I'm going to tell you a bit of a story about what happened to us through the COVID-19 experience. And then hopefully we'll have a bit of time. We'll actually show you a dashboard, or I've got an image at the very least anyway.
Yeah.
We've also got Rory McHugh, who's joined this morning, who's actually the person that built most of this stuff. So it's brilliant that we've got him here. So the story, what happened? Right. Starting in the top left, that's where we're normally based in Leeds. And one of the ways that we would informally describe ourselves in the past was as being the best kept secret in the NHS. The reason for that is that nobody had ever heard of the National Institute for Health Research until recently. And yet we're a pretty big organisation. The part that we are called the Clinical Research Network, we fund around about 7,000 staff up and down the country. We're in every single NHS trust in England. We have links to the devolved nations as well. And what we're there for is to provide the infrastructure for running clinical trials. And what that means usually is that we fund 15 regional organisations. They in turn support NHS trusts by giving them usually research nurses, And that means that when you find yourself coming into hospital and you are sick, somebody would approach you, funded by us, and say, are you aware? You may not be aware, but you potentially eligible for a clinical trial. Would you be interested in participating? Our role from that building in Leeds is to run that system nationally. And as part of that, we have a small but beautifully formed business intelligence team. Consists of around about 6 analysts, and then there's a few other people that do roles around things like data quality and so on. And that's where we were when COVID hit. And then, like many of you, I'm sure, we very, very quickly ended up working from home. In fact, we were about to plan in February to do a little test of whether half of our organization could work from home when the announcement was made that we should probably all do it. So the next day, very few people walked into that building, but if they did, they walked out with screens and cameras under their arms and went home. And that's where we've been ever since. As you can see, I'm still there, and where we're going to be for a while longer. Pretty quickly, the government announced that its strategy for solving research had several arms to it. And one of the most important, one of the important ones was research, because as you'll all be aware, the only ways we're going to get out of this situation is if we find a treatment or a vaccine or a cure that really, really helps. So we dedicated ourselves to that task and were pretty quickly asked by the government to change our emphasis to make everything that we did primarily about what we call urgent public health. So that's any kind of research that was going to help the current crisis. We didn't suspend everything else, but you'll be well aware that hospitals emptied and other treatments were cancelled. So it's difficult, for example, to run a cancer trial in a hospital if cancer services are not running. So our normal work, which would usually see us recruit around 800,000 people a year into different trials and studies, was severely affected. But as a national body, we moved to doing this. So quickly, we formed this thing called CABRA. Now, you'll have heard of COBRA, gets mentioned on the news, which is, the government's emergency response thing. So our organization formed CABRA, which stands for the Kitchen and Bedrooms Research Advisory Group. But this was an incredible thing that happened. So we had at one point around about 80 national experts. So you're talking about some of the most eminent researchers and doctors and epidemiologists in the country joined this group to rapidly look and see if there was any potential research that could be delivered. Now, bearing in mind, with a fair wind, most research studies would go from concept to recruiting a patient in about 18 months. This group was formed in about 5 days, and then it approved its first study around about 5 days after that. So there was an astonishing effort to make that work behind the scenes. And that's where my little image there of data wrangling came in. Because everybody in our organization suddenly had to work in a new role, had to do something different. And that included everybody in our business intelligence team. In the beginning, what that meant was, frankly, just helping to support that process. And the team used its skills at wrangling spreadsheets, basically, Google Sheets. So we built a research application system on the back of, the less people know about how that was done and sausages are made, the better. But essentially, we used our skills where we could to support those people in their kitchens and their bedrooms to make rapid, really important decisions about COVID clinical research. Once we'd established that process, it was flooded with inquiries. They have had to review hundreds. They met 3 times a week in the evening and on weekends. Quickly we ended up with a portfolio of research that we could work on, and then our role as an organization was to deploy that across the country as quickly as we possibly could. Now, in normal times, our business intelligence team is fantastic, does a wonderful job, but what it is asked to do and tasked to do mostly is retrospective reporting. It's saying what happened last week or last month or last year, and it's often about KPIs and that kind of thing. Now, the team is capable of much more and does much more rich analysis than that, but that is kind of what the ask is. But suddenly we found ourselves right in the middle of a national crisis. And that's when NHS England came in. Now, we have a database that contains around about 10 years worth of data on research activity, is what we would call it. So where have studies opened? Where did they recruit participants? When did they close? That kind of stuff. And we can build dashboards and things around that. But what was really, really crucial in the middle of the crisis was that we got ahead of what happened as well as we could. You can imagine that the Department of Health wanted to know, have you got this study open now? Is it going to open tomorrow? Have you recruited any participants? Because they were being asked daily, hourly by the media, what are you doing about this? That meant that we had an opportunity, but also quite a lot of pressure. So what we did was we rapidly built a brand new dashboard that took the data that we had, we put in a new process to collect information. We would normally collect information on study recruits, either be a mixture, but many studies would only do it once a month. And we went on these studies to ask for a daily update, which you can imagine the processes behind that were interesting, all done at speed. And we built a dashboard that allowed people to see where research was taking place, or where the first participants were recruited. Now, that then quickly led us to be quite visible and known as the only people who could say anything about what was going on with research in the country. So our dashboard became the source of truth for the UK government pretty quickly, which is scrutiny that we're not used to, but I think we could probably say that we enjoyed it some of the time. Now this really changed, and it went up a level when we were able to develop a better relationship with NHS England, who we've worked with previously, but they were also rapidly changing all of their systems and processes. And they were able to supply us a daily feed of data on where patients had been admitted with COVID-19, exactly which hospital they were in, how many people were on a ventilator, how many people were in a critical condition, and so on. And we could then feed that into our data. So we could say exactly where patients were being recruited, but more importantly, we could say, this is where the patients are today. This is where there's a cluster. And that totally changed the game for our organization and changed the way that people think about the way that research can be delivered. I put the image there of Boris Johnson and Chris Whitty and Patrick Vallance, because I'm sure back in the day you were all glued to the daily briefings. I'll tell a little story about what happened to us. We built this dashboard and we managed to get the daily data, and that meant we could report it. We did that for internal management purposes to help those 7,000 staff to plan what they were doing. But news spread to the Department of Health that we could do that. And I woke up one morning and logged on about 8 o'clock. And somebody said, could you do this daily and send it to the Department of Health? And I said, well, yes, I think we could. By 10 o'clock, somebody in the Department of Health had said, we really want you to do this. By about 1 o'clock, we'd formally agreed to do it. By then, we then had to tell the team, look, we're going to have to do this, do a daily report that is going to the Department of Health. It has to be the source of truth. It has to be 7 days a week, which is not the way we normally work. And it has to start from tomorrow. It was a Friday just before a bank holiday weekend. And then at 5 o'clock that day, we found that as people kept being added to the mailing list of who wanted to receive it, and Chris Whitty's name made it onto the mailing list at about 5 o'clock. So we went from being, a small team in the best kept secret of the NHS to right in the heart of what was going on with the coronavirus pandemic. And data was at the heart of it. And data linkage was what made the difference. So I mentioned that we got data from NHS England. We also started to feed in information from Public Health England on where people were being tested and the results of tests. And we already, in the background of our dashboards, we have data from ONS on population and so on and so forth. So what happened? Well, to this morning, I went and had a look at the dashboard. We've got more than 175,000 participants in COVID research. I'm pretty confident that that will be many more than anywhere else in the world. The sad truth is we had a very high incidence of COVID-19. That meant there were more people that you could recruit into research, but we did it incredibly effectively. The CABRA group approved 58 studies. And we recruited 12,000 participants to the recovery trial. But the recovery trial is the one that made the news. And here's a tweet from Chris Whitty saying that this was the first real study in the world that showed a significant difference in reducing the risk of dying. And in fact, we saw a treatment effect from dexamethasone that you don't normally see in clinical research. The numbers have gone out of my head, but it's something like 1/3 of people who find themselves on a ventilator and more will survive if they are given this drug. That's an incredible treatment effect. The BI team is now become central to research planning. So people use our dashboards to decide where to open research, because we can say, this is where people are testing positive. This is where they're being admitted. This is where there are study sites open. Don't open one there because there's a conflicting one. And we're now actively part of the planning for COVID vaccines research. And this is a separate thing. I don't think our team can claim credit for this, or we've contributed to it. But I'd encourage you to take a look at the website address that I put there and be part of research, because we've built a registry where you can volunteer to be contacted if vaccine research becomes available in your area. And we've got more than 225,000 volunteers for that in a very short period of time. I probably duty bound to say that if you sign up for that, then you would be properly consented into anything if they ever contacted you, and you would be guided through all processes. But if you feel like you would like to contribute to this effort, then please sign up there. So that's it for our story. I'm just going to stop sharing that because I have no idea what time it is. I've talked for quite a long time. And I don't know, we could show the dashboard in a bit more detail, but I've kind of given you an impression of what's there. So,
yeah, I think we'd all like to see the dashboard.
Okay, right then. Just let me.
This is full data geek world. They'll be gentle with us. Show us the dashboard.
Okay, I'm just going to get it. I don't have it.
And then I've got a couple of questions whilst you're doing that.
Yep.
One of the things we talked about at Open Data Science Lives is give the data back. So all of that data you'll be presenting will have been collected from SITREP reports, from different CCGs, from different places all across the country. And a big question that's been set up is, okay, lots of people are putting the data in, but do they get the data back? So the people contributing to the dashboard, is that available to them? Is it available openly? Is it available just to the NHS? Is it available only to Chris Whitty?
No, I'd love to say it was properly open, but it's not quite. It is open to anybody that works for the NHS, anybody that works for the National Institute for Health or the Department of Health or any of those bodies. We have to restrict it. It's not actually about keeping it closed. It's just the system we built it on can't cope with public access, and we don't.
Right, we can help you.
I know you guys can do that. At the moment, we don't even have time to think about that. What's been really nice is that we needed a lot of the data rapidly, and it wasn't available on websites. But when NHS England got involved, within about 5 hours, I was given permission to get their daily feed of data. Now, I don't even think I could have got a meeting in 5 weeks in normal times. You know? So it's changed the way we think about sharing data. And sorry, that wasn't a criticism of NHS England if it sounded that way. It's just, we're big organizations and it can be hard. Right, I've got this dashboard now, so I'll just share my screen again.
Excellent.
And then, actually, we should have got Rory to demonstrate this, but he can just sit back and relax. Right, so hopefully you can see that. We built 4 different things, but I think the one that I will show you is this one, which is, see that okay?
Yeah.
So what we've got here is this first thing, this is our live sort of daily tracker. So we get a subset of data every day from all of these 58 approved studies. They have to supply it to us. So, but they can then see this back. The Department of Health can see it. All of those people across the country that are working on day-to-day on planning research can see it too. We've got another dashboard here, which just shows that, on some charts and things like this. This is built in ClickView, by the way. So I don't know if I'm sure you're all familiar with that as a tool. But I'll just quickly show you some of the cooler features of it. So if we look at admissions and patients, that's the kind of thing that I was telling you about. So we can look at the most recent, so it's 3 days behind. That's to do with the cycle. So if anybody's here from Salford or around there, you can see that we've got a small cluster, but it's 5 patients. If you look back over, we can look at the rolling 2-week average, and you see a slightly different picture. And we show all this data. We've got people who, as the absolute numbers of cases have gone down, it's become even more crucial that we can say, look, there's 10 people in that hospital, go and try and recruit them into research. So that's that one. The site targeting one builds on something that we've been working on for a few years, where what we're trying to do is to say where might be a good place to open a study. So we've got things like admissions figures for different studies, and which trials they're recruiting to, and that kind of stuff. And all of this is filterable, and you can play with it like that. Recruitment per admissions was a really interesting one. So if I just select, sorry, I need to choose just pick that over there. So I've just picked interventional studies, which is, if you're not familiar, most people are familiar with the concept of like a drug trial. That would be an interventional study. You're giving an intervention. So would be a rehabilitation study. But we also do observational studies where we're just looking at data and things like that. So with this tool, we can look at, let's just say, where are we? We're mostly in Yorkshire and the Humber, aren't we? So let's pick that region. So if I do that, we can see the estimate of the number of recruitment per admissions over time and things like that. Now, that was really helpful.
Stephen, can I, sorry, I'm going to need to chair a little bit.
Yeah, okay.
There's quite a few questions coming through, and then we need to just go through our dashboard, and then I'd
Sure.
really love people to tell us what will be. This is amazing, and I think this includes lots of data that lots of people have been asking for, which is, how do we present information? Where is this? And I really like the fact that you think there's no reason why this data couldn't be open. It's just we don't quite have the infrastructure available to make it workable. I had a conversation with NHS Digital last week was with how we can improve the open data and how they could help others in the whole ecosystem build the infrastructure that could make all this work. So I think the very fact that Open Data Saves Lives exists, and we can broker that conversation between NHS Digital, yourselves, and NHS England to say, look, this data exists, it's already there. Maybe we could build a data layer and let other people build their own Power BI, ClickView, whatever presentation layers on top would be amazing. I know Mark's mentioned that on the chat.
Cool.
So I'm just going to take the questions in the chat so that I think
I'm just looking down them.
Rory's answered them, which is great, which is exactly what should be happening. Peter's asked whether we could share some screenshots of that. Are you okay with that?
Yeah, we can do that. Yeah, probably what might be better is if we take some screenshots and send them to you, and then you distribute them. Is that okay? Yeah,
that's perfect.
We'll
do
perfect.
That. And then could we open a conversation? I know you got to scoot at 11:30, but if Rory could stay on, we would like to open a big conversation about dashboarding and presenting information, because I don't know about you, I've heard a lot about the dashboard wars that are going on internally, and it really, we're not really interested in that. We just like to build some really great data infrastructure that other people can build and answer the question that's right now. So, and the dashboard will never answer the question that people have next week, because we don't know what question that is next week, do we? So it's impossible. So that was fantastic. And would anyone else like to make a question before Stephen has to scoot off? Other than, well done, sounds like you did an amazing job. And this is a resource that I wasn't sure existed, but obviously it did. And I think there'd be lots of people who would be, that we can build some momentum around that and share some of the outputs. It's looks like a fantastic resource.
Thanks. Yeah, and we'd love to, Rory and I and the rest of the team would love to you know, have more of a conversation where we're both actually quite passionate about the idea of open data.
Cool.
Just, you can imagine we've been a bit busy.
Yeah. Yeah. I think, so this is,
any
this is
help
fantastic.
would be appreciated.
Yeah. So we'll share this. We'll obviously the talk's been recorded, and we'll maybe get in touch with you to do a little blog post about it,
Cool.
which would be amazing. So Amy and Grace, if you can take that as an action, so that'll be fab. Okay. So if there's no more questions, and Hannah there from Data North. So if you didn't know, the one of the largest open data platforms in the UK is in Leeds too. So I'm pretty sure that between us, we might be able to help you get that open and be able to cope with the number of inquiries and things that might happen. So yeah, great.
Brilliant. Thank you for the invitation.
Yeah, fantastic. So, Terry, have you got a question there? Oh, you're on mute.
Okay. I've dropped it into chat. It says simply, have we reached out to Johns Hopkins on this uni in Baltimore?
We've not specifically reached out, but I'm sure other people have been talking and accessing their data. But Stephen, have you got?
I know exactly what you're talking about. We haven't, simply on the grounds that we're focused on England. So our role is to plan research in England and the devolved nations when it comes to this urgent public health stuff. But it's a good idea. We probably should, because if we were to link up with what they're doing, maybe we could say something about the global effort as well. It's a good point. Thank you.
Cool. Great point, Terry. And I think we all need to start thinking broader and wider and not trying to build everything ourselves. There's lots of great stuff that already exists. Hannah from Data North had to scoot off as well. So, but I think we'll be doing a bit of matchmaking of how we do that. So, Stuart Lowe from ODI Leeds is up next. I'm a great believer in actually to understand data, you've got to use it. So we thought about what would be useful, and we built lots of national dashboards and hex maps. And I don't know if you saw yesterday that looks like number 10 and NHS are using our hex map. So that's great. So we built the West Yorkshire dashboard using the API from PHE England. And Stuart's just going to talk you through what happened, what we did, and also where we're at. And then we'd like to ask you all some questions about what we think would be useful for other people in terms of a dashboard. So over to you, Stuart.
Right. Okay. I just done that last thing. I think, did Tom White say last time that his data is being used by Johns Hopkins, or was that someone else? I mean, his compiled data of the UK from
yes,
4 nations. Anyway, let me share my screen. If I can find the right one. Yep. Okay, so we started making a dashboard back in March, and we started trying to use PHE data, but it was only covering England. So we switched to Tom White's data because whenever you start doing UK type things, people from Scotland and Wales and Northern Ireland quite rightly say, why is it only including England? So we used Tom White's compile data. He stopped compiling that, as he mentioned, at the last Open Data Saves Lives at the end of August. So we deprecated this dashboard. Hopefully you can see this. We've still been generating hex maps. They don't always include the whole of the UK. Sometimes it's England, sometimes England and Wales, sometimes it's combinations of nations. It has confirmed cases per capita, latest cases. We've got a 7-day average. I'll come back to that a bit later. 7-day average per capita, because that changes the story a little bit. We've got, hopefully you can see the fraction of key workers. Also, if you hover over it, it gives you the details for each local authority. So I should say these are hex maps, local authority based hexes. So every local authority is given the same area in the visualization. I haven't seen the thing that you mentioned, Paul, about the government using hex map. Anyway, it's also got all deaths per capita using ONS data, and then what number of them are COVID deaths, and then the fraction of COVID deaths compared to all deaths. So each of these hex maps tells a slightly different story, and I think you need to look at the notes underneath to work out what's going on, but also use some sense of what you know about the country to work out what the stories are. For instance, like the deaths, the coasts clearly have slightly higher rates of deaths, and I'm assuming that's because people who are retired tend to move to coastal areas, and you'd expect more deaths, and that's why the coast doesn't show up in the COVID deaths in quite the same way as it does in just all deaths. We also have some data which I'm going to update to the August figures, and then hopefully the September figures, which is the self-employment income support scheme, and value of claims and average value of claims, and the total number of claims. And then we've got employment's furloughed and things like that. We've also got some 360 giving data, because David Kane at 360 Giving was very good at producing local authority splits of data. So I can show where the grants that are known to 360 Giving, that are published in the 360 Giving format, where they're being awarded to. So that doesn't necessarily tell you where grants are being spent or where all grants are being awarded, but it tells you where the ones that are published in the open standard are being received. Okay, so we did that. This is the Public Health England and NHS X dashboard that probably most people know about, coronavirus.data.gov.uk. It also has the data published there. Now, I sort of prefer CSV files for quite a lot of reasons. One, they're quite usable in lots of tools and they're very easy to consume. Also, it means as long as you've got a local copy of that CSV file, you can make stuff with it and you're not reliant on other bits of infrastructure falling over. But Paul asked me to, I can't actually get to the right tab because the Zoom stuff is in the way. So let me see if we can get to it. There is an API for using it, and we decided to try to use the API from Public Health England for a West Yorkshire specific dashboard. So this is very specific to the 5 local authorities in West Yorkshire. We just put them in alphabetical order there. They're not in order of anything else. And the colours are just purely colours from each of the council's websites that they choose to use to give you your eye a chance to realise that they're in columns. So we're using the Public Health England API and making requests, which is why this dashboard doesn't always work, because sometimes the API seems to slightly fall over or not respond, so we don't always get data in the page. But when it's working, like there, you can, this is a few minutes ago, you can see their latest data. So we're showing the total cases by local authority. It's basically making 5 requests, 1 for each local authority. It gives you the dates when that data was true, because you can't rely on it always being today or even necessarily yesterday. Just in the last 6 months or so, sometimes some local authorities have missed days of data, and so I'm making sure to put the date so that you know when it refers to. I'm calculating weekly cases, and Paul, I think, has had a discussion with Bradford Council because they have a dashboard as well. They're calculating weekly cases in a different way. Perhaps naively, but I think most people assume that weekly cases is a 7-day total. Obviously, that's every day in the 7 days doesn't have the same number of cases, because weekends we know have fewer. So I think Bradford are omitting weekends, but they're still having 7 days, which I presume that's to get rid of a weekend effect, but presumably then can have depending on which day you look at it, could have a double Monday effect. I thought I'd go with the most obvious thing, which is the 7 days up to the date that's shown there, because that's what I would naively expect as a member of the public weekly cases to mean. And then we've got the change on the previous week using the previous 7 days to that. Then we've got the total cases per 100,000, weekly cases per 100,000, using the population figures from the top there. Weekly COVID deaths, total COVID deaths, that's using the ONS data. Actually, yeah, so there's 2 data sources here. Some of it is coming from my processing of the ONS weekly data, which is what these deaths by week at the bottom here. And then we've got the COVID deaths as a % of total deaths. So I'm not sure necessarily if every figure on there is useful, but we've had some feedback from people in West Yorkshire saying that it was helpful for them to see things changing. Yeah, that's probably a very quick summary of that, Paul.
Thanks, Stuart. And we've learned a lot by just using the data and putting a dashboard up and getting some feedback. We have quite a lot of people saying, my dashboard's better than your dashboard, but those dashboards aren't public.
Actually, So I can maybe just add, it's good to separate publishing the data from the dashboard.
Yes.
And don't think of the two as one thing.
Yeah.
Make sure you publish the data well, preferably openly somewhere, and then everyone can build however dashboards they like on top of that. But rather than go dashboard first, go data first, and then let other people make dashboards maybe.
Yeah.
Obviously dashboards are very useful, but if the data is not there widely available, then it's limited to that particular thing that you've created.
Okay, so yeah, it's great work, and I think we've had some really good feedback about how clear it is for people to try and understand. That the problem is when data doesn't present, or if we're using the data that's published by PHE England, or Public Health England, so that we're trying to standardise what we've got. But when people have other metrics or data that they're publishing, which isn't open, and then they compare it with ours, it's very difficult to have a consistent approach. So Terry just made a comment that I'm going to put that in the Google Doc, the work that's happening in Cambridge. And Mark's made a point around how we get consistent and how we might normalise the data and get some really understanding about consistent approaches to that, which is great. Before we ask for people to spend 10 or 15 minutes giving us some suggestions about what we might do next with our dashboard, would anyone like to make any comments or questions around the work that Stuart's already done? So yeah, Mark, go.
I want to just reinforce that comment. So I probably didn't make it as loudly as I should. It kind of occurs to me there's lots of people doing amazing work and they're on here. But
yeah.
Until you create a stronger reason for people to look at them, you won't get them in front of the senior people in suits. So if you take what Stuart's done there, for example, and extend it by linking it into forecast models and those types of things, because working in hospital, what people want me to tell them at board every Wednesday is, what do I need to worry about? When's it coming?
Mm-hmm.
How do I get ready? Where's it going wrong? And so on. So get the data, get it out there, absolutely. And I think the next step is why making it sticky, as we call it, which is why you would have to know these numbers every day. So in my trust every day, people need to know how many people have got COVID. So it's 3 today. And that number is in everyone's head.
Yeah. And
they need to know how many people got admitted yesterday with COVID. And if that number is statistically significantly different, given the 7-day rolling average or something, there's something about making the next step of making it, you need to know these numbers, you need to look at Stuart's stuff because it's tipping you off about something. And I think we haven't quite made that next link yet.
Yes.
We've done some really cool stuff in grabbing the data and linking it and getting it out there. But you now need to, you now need to put the number of the hospitalisation alongside the number of cases, because that is the debate at the moment. Does it matter that cases are up if hospitalisation's low? And if you made that next step and linked them and said, we now have a view as an open source community that you do need to worry or don't need to worry, that's when it's suddenly you get everyone's attention.
Yeah. Okay.
Yeah, and Mark, just to add to that, obviously the things that are important to tally up with the data are different based on if you're in a hospital or if you're in public health more generally, or if you're and the police or whatever. There's different angles, and I think identifying those is a really great thing to start doing.
Okay, so I've just
can I just explain my
go Stuart. Yeah,
it would also be good if the Public Health England NHS API also had the number of tests done by local authority, because at the moment we get the number of cases by local authority, but Birmingham has a huge population as a local authority, and so it always looks cases wise as if it's the worst place in the country. But without knowing how many tests were done, we don't know what the rate is of positives, and therefore comparing local authorities is very hard. I know people in Manchester have been trying to get that data published, and I think they were told to ask individual local authorities, but if we have to ask 380 local authorities to publish data, that seems like a very slow process that probably won't result in many local authorities publishing. So if Public Health England could do that, that would be great.
Stuff. Mark, would it be possible for us to work with you and have the, what are the 5 questions that people are asking Kent CCG for? And then
yeah, absolutely. And
we can maybe
show that.
Yeah. And then I'm sure
Stuart's point, that should be what Stuart just asked for, should be possible. You should be able to do population adjusted forecasts. That should be within our gift to do, because then it gets really interesting.
Yeah.
But
so if we have, so Giles, if we can add that to our workflow, Giles, and then maybe we can start convening and working with people about how we collectively. So if we could collectively show those forecasts, that then becomes very powerful. And the data team at ODI Leeds and the data team at Kent CCG and Beautiful Info and others could join in and say, look, could we get this together? And I'm pretty sure it looks like the NIHR have a lot of that, some of that data that has been collected in one place. So maybe there's some goodwill there that's been put together. And also NHS Digital have asked me, and if they've asked us, if you like Open Data Saves Lives, to help them do more with open data. So hopefully I've got a call with them this week or next week about saying, okay, this is what you should do. And they might be able to support it. So we'll be catching up with Alistair Bulwood and the Open Data team at NHS Digital to help them with that. So if I can ask everyone just to make some suggestions like Mark has done about what would be useful, that would be amazing. You might see my Twitter conversation with Dan Cookson about what's good geography, how we should present things and how we shouldn't do that. But I think that's another question as well. Of I may be taking an obtuse, radical position to try and tease out what should actually be done, and whether we should publish maps like the John Snow map, which is very, very detailed and down to building level, or what is the actual geography that makes sense to normal people. So how do I tell my mum not to worry or not? Okay, so geography's a part. Good. And then is there anything, is there a sort of a magic dream state that that people would like to see in a dashboard, or other people have shared with us saying, I would love to see this? I'm going to ask Peter Wells to join in, because I know that he's been thinking a lot about this.
No, he hasn't. I was actually just typing one thing in as a suggestion, but it's a quick thing, which is in terms of what questions people are interested in, and tying that to things, and as Mark said, things that get to senior decision makers. If you look at the NHS England Test and Trace contact tracing app, then that allows me to type in the first part of my postcode, and it gives me a risk profile to my area.
Okay, yeah.
So that will be based on something. I don't know quite what that something is, because it's quite hard to get that out of people.
Mm-hmm.
But there might be something there that's useful, and it means that the NHS Test and Trace team might be interested.
Fine, right. Thanks for that. Cool. We'll take that as a note. So Grace and Amy, if you can get that in the Google Doc.
I can intro you to the program director if you don't know them already.
That'd be great. So it's now 11:45. I am happy that we're going to actually finish Open Data Saves Lives roughly on time, so with about 45 minutes. What I'd like to do is just let you know about the next one, which is going to be part of Leeds Digital Festival. We've got 3 speakers. So we've got Tom Reardon, CEO of Leeds City Council, but also was the first person into Test and Trace to help run that. So he's going to talk to us about how Test and Trace was set up and running and the challenges they've got. So that's really interesting. We've got Chris from TPP, who's going to talk about Open Safely and the work he's been doing with Ben Goldacre, which is, again, an amazing piece of work. And they've just released a whole load of new stuff around that data. So 25 million pieces of data all worked in safely and then openly published. So that's another amazing piece of work and something we're very proud of in Leeds, because TPP have worked on that. And Alistair Bulwood as well from NHS Digital are going to talk about and take questions on their open data publishing frameworks and what they've been doing. And if you ask him nicely, he might talk about the dashboard wars that have been going on in the NHS. And what I want to take is obviously everyone's invited. It's going to be a little bit more high profile, and we're going to make a bit more noise about it. So if you could all join in with making some noise about that, that'll be grand.
Paul, did you say the date for that? I know you said it's Leeds Digital Festival. I don't think you mentioned the date.
2 weeks today.
It's 2 weeks today, right?
Yeah, 24th. And myself, and there's also going to be an announcement of that. So myself and Mark Farr are going to talk a little bit more about what Open Data Saves Lives is going to do more of as well. So as well as we've done a lot in the last 6 to 7 months. Hopefully we're going to have some good news about some collaborations we're going to be doing in the future around Open Data Saves Lives and amplifying and supercharging our work. So tune in for that as well. So we're nearly up to 50 minutes. It's been 47 minutes. Thanks very much for joining us. I think that's really good. And I don't know about you, I've learned a lot about the NIHR's dashboard that I didn't know. It's got a lot more in it than I expected. So hopefully we can get all that published. So thanks very much, everyone. See you later. Cheers.